Welcome to today's webinar. My name is Monica Ranta, and I'm a Vice President of International Sales at LKC Technologies, a manufacturer of visual electrophysiology. I am really honored to have the opportunity to be a moderator for the section 3 of our series, Women in Visual Electrophysiology. In the past 45 years, our team has seen the tremendous progress in research made by women, and my two female colleagues and me decided to honor those achievements by creating this series. Today, I welcome Dr. Xiaoian Ding from Guangdong, China, for a presentation of her work about a non-invasive ERG in pediatric patients with suspected inherited retinal disease. Welcome.
Hi, Monica. Hi, nice to meet you. Nice to meet everyone here.
Yes, we have lots of attendees from all over the world, so it was very difficult to choose, is it good morning, is it a good afternoon? And before we start, I would like to present how to choose the proper language. This session is very special for us because we have a live translation into 3 languages: Chinese, German, and Portuguese, or I would say Portuguese, German, and Chinese, as it says on our screen. So for all of you that would like to hear the presentation and our discussion in your preferred language, any of those 3, please go to this link that you see here, gokanda.de/en/LKC Technologies. Type the password LKC 2021. You will see this screen. Choose the language of your preferences. When you have done that, please don't forget to go back to GoToWebinar. Open the function audio by pressing this little triangle. It will open the options for you. Please choose no audio. This way, all the presentations, all the discussions we have right now will be delivered in your preferred language. Before we go on, a few words at our today's speaker, Dr. Ding. Dr. Ding serves in several positions, and I have very selectively choose few to share with you. So she is the chief physician and doctoral tutor at the Fundus Disease Center. She is a deputy director of the Youth Committee Ophthalmology for a Chinese Women Physicians Association. Now you can understand why she is representing Asia Pacific in our series. She is a deputy director of the Children's Eye Care Specialty at the Guangdong Maternal and Child Health Association. But not only that, I have to tell you that Dr. Ding is, for me, a master of multitasking. She's working at a very busy clinic. I have visited the clinic, so I know what I talk about. She's also doing a lot of research. She is the author of 110 articles, over 50 scientific papers. Out of them, 26, she is the first or corresponding author. And there is one more thing among the prizes, grants, all the things she achieved in her life is a prize for the outstanding teaching. Dr. Ding got this prize twice. And I hope you all agree with me that the teaching and sharing the knowledge is very important to develop the medicine. So that's why we have you here, Dr. Ding. Welcome once again.
Thank you. I'm so happy to be here today.
Before we go, I have to ask you the question. You know, visual electrophysiology is not the most popular among students. So why did you become interested in the visual electrophysiology?
Okay, so you are right. You just said visual electrophysiology is not the most popular one. I agree with you. So for the popular one, I guess in these 2 decades, perhaps OCT or slow is very popular. But both the OCT or slow can tell us what the retina looks like, but have not tell us how the retina work well or not. ERG can tell us if the cells in the retina, including photoreceptor, bipolar cells, Mueller cells, ganglion cells, all of them, works well or not. In many diseases, function changes prior to the structure. So that's why I am very interested in the ERG. And I guess it's 8 years ago, when I began to change from the adults retina to the pediatric retina, there are so many diseases I have not met before. I didn't know their name. So how to get the right diagnosis, I have no idea. But I realized it is so important if we can know ERG, we can use ERG or BEP in such kind of disease. So that is so critical to get the right diagnosis and to achieve the possible early treatment. So that's why I focused on the ERG and BEP for so many years.
Thank you. I agree with you. The children cannot tell us what's wrong. We just see the symptoms, but it's difficult to find what is the real stage. Yes. And last question before we go to your fantastic presentation. So what would you consider as the most challenging aspect during your career?
Okay, the most challenging part, I guess, I have been a retinal surgeon for about 20 years. For the first 10 years, I was focused on the regular retinal disease, mainly in the adults. And I did some research in age-related macular disease. And about 8 years ago, I began to do the pediatric retina. Oh my God, the pediatric retina, that is really a new world, a new world. The very interesting thing and the very tricky things is that some disease, for example, the very common disease in vitreoretinal department, the retinal detachment. In adults and in the pediatrics, the retinal detachment, they share the same name, but they only share the same name. The underlying mechanism, the clinical features, and the prognosis, all of these, they are totally different. In the pediatric patients, the prognosis is poor, it's very poor. So we need to do more work. I struggled for a long period, about 5 years, I guess. So that's my most challenging part. But the good news is after 8 years, I think I is a good pediatric retinal surgeon now.
I am sure about it. I'm really happy to hear that, and I'm really honored to have you. Before we go again, I would like to show our audience how to ask questions. On every session in our series, Women in Visual Electrophysiology, we have received lots of questions. So on the left part of your screen, you will see how to ask the question of the desktop application. Again, this little triangle in the question part lets you type in your question. If you are using the mobile device, that's the option that is visible on the right. And we will be able to answer the questions in English due to the fact of my language limitations. But if you are the Portuguese speaking, Chinese speaking, or German speaking, and you want to ask questions in your local language, please do that. We will translate it and we will respond later in the messages. So I would like to welcome you again, Dr. Dink, to present what you achieve in the field of the inherited diseases.
Thank you. Hi everyone, nice to meet you. This is Xiaoian Ding from Zhongshan Ophthalmic Center, Xiaoyan University. So our ophthalmic center is at the south gate of China. Today, I would like to share with you my daily clinical practice. It is about a non-invasive ERG in pediatric patients with suspected inherited retinal disease. Okay, so today I will talk about why is ERG important and what we are facing now. I will introduce a little bit a novel device, a handheld ERG, and share with you some consideration in my pediatric ERG practice. And finally, I will share with you some interesting cases. When your patient is adult, it is so easy. We can take the photography for the patients. We can do the OCT, do the FFA, even we can do OCTA. Now we have the wide field photography. We have so many fancy things, and photography and OCT have already become the first-line recording and diagnostic tools. It is so easy. That's our routine. However, when your patient is a child, what will happen? The baby cannot tell. The baby is in poor compliance. What we can do? Here, I will show you two small videos. Perhaps it will make you uncomfortable because it is very noisy. There is baby crying. Have you ready for that? Okay, go. This is the routine way we did the photography for a congenital cataract baby. The baby is not sedated because she is so tiny. And here I will show you how we make OCT possible in a child, like this way. The baby is sedated. We really need the help from her parents and our experienced technicians. But this is only for some examination. We can get the structure of the eye, structure of the retina. If we need some functional analysis of the retina, what we can do? The only thing is we can only check the visual acuity. But visual acuity in baby is so difficult to be accessed. We have a lot of ways for the patients, for the kids who is under 3 years old. Perhaps we need to do teleacuity chart. It is time consuming. It takes about half an hour for one baby. And if the baby is 3 to 4 years old, perhaps point acuity chart will be okay. And if it's a little bit older, in some preschool babies, symbol chart is okay, but it is so difficult. The most important thing, the visual acuity is subjective. It is not objective things. So what we can do? Can we got another things, something objective, something is real? Yes, we have the answer. We need ERG. Most ophthalmologists believe that ERG is the best for the early detection of retinal and optic nerve disease. ERG is significantly valuable in children with possible inherited retinal disease, and sometimes ERG can even help us in confirming and follow up some not ocular disease, but systemic disease, just like brain tumors and autism. In one word, ERG is the best. However, ERG is not used so much in our real world. Everyone thinks ERG should be available for any healthcare professional and patient in need, but it is not. Everyone thinks ERG can be easily performed and understood. Actually, it is not. I would like to use one word, marginal. ERG is now marginal in our daily practice because if we want to do an ERG examination, we need a very complicated devices, and the process is so complicated, just like this one. There is a lot of cables in front of the head and at the back of the head, and what we can do in even such small babies. And in small babies, sedation is needed. It is less reliable, and it is difficult to recording and interpreting the results. So I guess some of you will think, I have forgotten ERG when I finish my medical school. It is not in my list. Can we improve it? Because you know, a lot of things, just like cell phone, 20 years ago we used this one and it became smaller but better 10 years ago. But now it is like this, it gets smaller but stronger. It's just like a computer. So I think we can improve it. Yes, we can improve. We now have the Retinal device. It is a fully portable, full-field ERG system. It became smaller. It is handheld. It is even shorter than a regular book. I just put my ophthalmology textbook here to show how small the device is. And it is better because it can be non-invasive with skin electrodes, including all 3 electrodes in it. It is stronger because we do not need to dilate the pupil anymore. And it is easier to read because can you see here there is 2 reticle here. Here it shows a normal value, so it is easier to read. Let's make a comparison. This picture is a little bit scaring, but how about this? We can say it is very peaceful because we do not need to open the eyelids anymore. This device can use the electrode of skin, and we do not need to open the eyelids. And with Retinal device, we can obtain full-field flash ERG, which measures the retina's electrical response to light, and we also can obtain flash VEP, which measures the brain's response to light. Okay, we all know what is full-field flash ERG can tell us. Here is the waves. The A wave comes from the photoreceptor, and the B wave comes from the bipolar cell and the Mueller cell, and also there is oscillating potentials, which comes from the Omicron cells and the horizontal cells, the loop. Okay, with this we can get a lot of information from in the retinal cells. And here I listed some common applications in my daily practice in the pediatric retinas, such like pediatric visual disorders as with nystagmus, glaucoma, acquired and inherited retinal disease in some children with night blindness and unexplained vision loss, and a lot of. But when I began to use this novel device, I found there is a problem because there are no reference data available in children under 6 years old, but the majority of my patients is under 6 years old. So I built the database with 200 healthy children from 4 months old to 16 years old. Here, there is something interesting I would like to share with you. Here is a lot of data and you can see the data with the age increase, the implicit time decrease, and the amplitude increase. I will show you in this picture. It is very interesting. If we look at the implicit time with the age, it becomes shorter until 6 years old, and then it became stable. So I would like to say, if we talk about the implicit time of ERG, the cut-off value, cut-off age is 6 years old. So in a children who is less than 6 years old, the implicit time is not stable. It decreases with the aging, with the age. And here we can see the implicit time is negatively correlated with the age in 6 years old and less. How about the amplitude? Yeah, not surprising, the amplitude increase with the age and then keep stable. But this time the cutoff age is not 6 years old. It is 9 years old. So I would like to say the retina in children is keeping developing until the child is 9 years old. Here we can see the amplitude is positively correlated with the age until 9 years old. And here I made a GIF photo to show the amplitude and the implicit time change with the age. You can see the amplitude became bigger and bigger when the age increased. And now I would like to share with you some interesting case. These cases are all from my real world, from my real practice. Okay, here is the case one. This is a boy, 4 years old. He was found to, the vision is very low during the pre-school screening, and the BCVA is 20/50. And the retina looks good in his left eye, but in his right eye, the macular is not so good. It is something like the spoken-like. And here, since he is 4 years old, OCT is available, and we get the OCT. It shows some cystoid lesion in his right eye, but the cystoid lesion is not so much in his left eye. So what will you do next? Will you do a FFA to exclude the CME, or do OCTA to see if the vessel have something wrong in the vessels? But my answer is to do a ERG with a ISF step 5 ERG. We can see a very interesting things. Look this. When you zoom in, we can get this. It is a negative ERG. We have the A wave here, a big A wave, but the B wave is too low. If the amplitude B to A is less than 1, we call it negative ERG. So this disease is XLRS, X-linked retinal schisis. X-linked retinal schisis is due to the RS1 gene mutation. It is usually noted in preschool boys. The early diagnosis is so difficult because there are no symptoms. The average visual acuity is about 0.3, that is 20/60. Negative ERG without a B wave is the golden standard for the diagnosis of this disease. So you see, ERG helps. Here is my case 2. Case 2 is also a boy who is 6 years old, and he has a little bit myopia here. So visual acuity is not so good. It is only 20 to 100 in his right eye and 20 160 in his left eye. And we also checked the axial lens, and the axial lens is matched to his myopia, a little bit longer than the normal. This patient came to our center at the 2018, and after the initial visit, he was asked to go to do the amblyopia treatment because the BCVA is not so good. However, after 2 years treatment, no improvement happened. Totally no improvement. The BCVA is still very low, but the myopia is quite stable. What's wrong with it? So this patient saw me at the end of the 2019. I did the OCT, but the OCT, the microstructure of the macula is perfect. Nothing is wrong. But why the visual acuity is so low? Then I go to the ERG. The scotopic ERG shows that the B wave is so low that means there is something wrong with the bipolar cell or Mueller cell. And again, negative ERG is coming. There is no B wave. Okay, negative ERG. Negative ERG is always happened in some disease, including inherited and acquired. The most of them is inherited disease, including congenital stationary night blindness, CSNB, X-linked retinal schisis. We have already seen one patient, and snowflake retinal degeneration, and some other disease. They are very rare. And negative ERG can also, in some acquired disease, retinal ischemia due to the CRAO or CRVO, MAR, or retinal toxicity. But all of the disease are common in adult patients, but not in a child. So we focused on the inherited disease, and among them, the most common one disease is CSNB. Then we move to the photopic ERG. From this ERG, we can see the photopic one, the B wave decreased a lot and the latency elongated. And to the flick ERG, everything is decreased. What's happened? Okay, so I would like to show you with what is CSNB will have, what is the ERG will in the CSNB. We have calcium control. I show it at this row. The wave should be like this, and we have two forms in CSNB. One is complete form, and another is incomplete form. So in the complete forms, they will have a normal B wave, but in the incomplete forms, the B wave is abnormal with very low amplitude and large latency. So that is what we have seen in this patient. So I suspect that this baby perhaps has the incomplete forms of the CSNB, which because he is also have some myopia, which is very common in CSNB. Okay, here is a genetic map of the CSNB. If we consider about the incomplete ones, there is 3 genes is related to the incomplete type. So I ask my colleague to check these 3 genes, and the result is here. This is a patient with the incomplete form of CSMB. It is due to the mutation of the CACNA1F homozygous mutations. So this is not a patient with a simple myopia, but he is a patient with CSMB. Finally, we got the diagnosis after 2 years. So I would like to share with you precise ERG phenotyping allows us direct targeted sequencing to establish the genetic diagnosis. And here is my case 3. Case 3 is a little girl, only 2 years old. She was noted to have nystagmus since 3 months old in both eyes, and we check the refractive error. It is positive 5, which is quite normal in a small baby. And here is the Rackham wide field photography. Nothing is wrong. It looks unremarkable. But she has nystagmus. Nystagmus in pediatric patients is common with a prevalence of 2.4 per 1,000. When we see a nystagmus patient, we should consider, is it primary or secondary? This answer is critical important because if it is a secondary, it should be related to ophthalmic disorder, something like retinal dystrophy, optic nerve abnormality. But if we cannot find any ophthalmic structure or pathology, we call it primary. And the early detecting is critical because, we now have some gene disease, they can be treated, something like LCA2 due to the RPE65 mutation. Okay, we did the A-B scan in this small girl. It looks good. And now we go to the ERG. The scotopic ERG shows unremarkable. It is good because you see all of the things is located in the rectal. And here is a photoptic ERG. Oops, the cone response extinguished. There is no waves, no A wave, no B wave, just like a line. And also the flicker ERG extinguished. So that tells us there should be something wrong with cone photoreceptor, So based on this baby we requested an OCT under sedation for this baby. And here is the answer. You can see the deletion of the EZ zone under the fovea in both eyes. So this is a baby with the cone dystrophy. And we check the family members. There is nothing happened in his parents. So we guess it should be follow a AR pattern or XL X-linked pattern. And with this, we check the mutations. There is something wrong in the CAGN3 genes, which could cause acromactopsia type 2. So this is a small baby with not the primary nystagmus, but the secondary. It is due to the acromactopsia. Acromactopsia is a hereditary visual disorder. So the baby will be absence with the color vision. The vision is decreased and decreased light sensitivity. And most importantly, there will be nystagmus. It is due to the absence of functioning coins. There is no functional coins. So there is about 6 genes we have found is related to this disease. I listed the genes listed here, and in this baby, it is due to the type 2 CNGA3. Fortunately, the this disease is not progressive. The baby are usually be able to attend mainstream school, so that's not so bad. But I think the early diagnosis in such kind of children will allow us to provide better genetic consulting. So today I shared some interesting case with you, and I would like to say we now in an era of precise medicine. In this era, ERG is of great help of many retinal disease. ERG is now becoming easier, faster, and easier to be understand. It is not so complicated. You can use it in your daily practice. And now we are also in genetic era. ERG might lead us more close to the precise diagnosis and possible early treatment. Thank you.
Thank you for the fantastic presentation, Dr. Ding. I just would like to refresh your memory how to ask the question. So in the control panel, you see this little triangle under the questions. Please type your questions in and we will respond to as many as we can. We have a little bit of time limitations, but we will do our best. So Dr. Ding, fantastic presentation. I think your data is really impressive and what you did. I think we all enjoyed that. Are you ready for questions?
Yes.
Perfect. Okay. So I start according to how they appeared. So the first question we got was, can Retinal do VEP tests? If yes, for which indications would you recommend using VEP?
Okay, so this is a question about the VEP. Okay, so first of all, this tiny device, the LKC device, can do the VEP also. So it is very fast, convenient. I did it for in a lot of children in my clinical practice. And so about the indications, in my clinical practice, we have a lot of children. They came to my clinic, and I checked the cornea, the lens, the retina. All of them looks good, but the visual acuity is not good, or their patients reported the visual acuity is perhaps not good because children cannot tell you what they feels like. And in these patients, I will go to the VEP regularly. And the possible diagnosis, the most common diagnosis in my clinic perhaps is labor. Leber's hereditary optic disc neuron, LHON, and also there is some DOA, the dominant optic disc atrophy. So, and some other disease I suspected the problem is from the optic disc or optic nerve.
Okay, thank you very much. I think that helped a lot the people to which test to choose. I would like to address the next question. First of all, There is a congratulations on collecting the 200 reference dataset. Question is, were recordings made from undilated pupils using the constant Roland settings? And secondly, it did not look like Chinese and American cohorts differed much. Did you expect that to be the case? If you wish, later I can repeat the second part of the question.
Okay, no problem. I think I get the questions. This is really, both of the questions are very good. So for the first one, actually at the very beginning of our study, we tried both. We tried undilated and then dilated pupil, and then we did the ERG again for the second time and compare them. See, there are no difference, totally no difference. So I believe that the dilation is not a question when we use this device. You can try both. And so this is the first one. And the second one, it is about the what is the question? I forgot that. Sorry. Okay.
Yeah.
So yeah. Yes, that's a very good news. So it means that it is not related to the race. There is no difference among the races. So we can use all of the data, no matter the data it comes from. So I would say it is comparable between Americans and Chinese, and I believe it is comparable among all of the races. So okay. That's good news.
Yeah, since we just in the meantime got the question about how likely are you to recommend us using your reference data on Pakistani kids, I think we can confirm what you just said, yes?
Yeah.
Okay, I think that many of the people working with children have a similar issues. So I go to the next one. What do you think about multifocal ERG or pattern ERG in children? When are those tests advisable?
Okay, so if we do the MFERG, that is means we are checking about the function of the macula. Also, it is the same for the pattern ERG. Both of the MFERG and pattern ERG is checking the macular function. Thus, the good fixation is necessary. From my experience, it is we can use only in the children in 6 years old and older in boys. But interesting, if the patient is a small girl, and the small girl is always with good compliance. So we can try it if the girl is about 5 years old and older. In my patients, I tried MFERG in some patients. The retina looks good. The OCT shows there is a little bit changes in the macular, and I guess the diagnosis perhaps is OMD, occult macular degeneration, and then another name is Miyake disease. This disease is quite popular in Asia, and in such kind of patients, I will use MFERG.
Okay, I have another question. Can you measure through the closed eyelid with Retinal?
You can try if the children close it, but if the child is under sedation, it is very convenient and it is very fast if you use if you open the eyelid with I don't know the name in the English actually.
I think that you mean the speculum?
Yes, yes, that's the word what I want to say.
Okay. I
And
have a question. Okay, sorry. Did you?
okay, so what I want to say is this device is very good if we use it in a patient who is 4 years and older. So no sedation is that's good.
Mhm. Okay. I have a question which is probably connected to the previous one. So you mentioned that Retinal can do tests with non-dilated eyes. What do you recommend using, dilated or non-dilated?
It depends. It depends. So you know, for pediatric patients, we always do not only one examination. So
Nós sempre fazemos várias examinações.
So perhaps we need ERG, and at the same time we need OCT fundoscopy. So for the OCT or fundoscopy, we need to dilation, and then go to ERG. But if you only do the ERG, forget dilation. It is okay if we don't dilate the people. That is okay.
Okay. Next question. Can I do colorblind test using ERG? Colorblind test using ERG. So if you have a children and you suspect that it's colorblind, can ERG help you to see the symptoms there?
Oh, you mean the colored blindness?
Yes.
Okay. Okay. Of course, because the color, the problem of the color problem, they are all comes from the cone. So ERG will tell you if the cone is good or not.
Okay. How does sedation anesthesia affect the ERG? So what kind of different results you see then if you use the sedation versus anesthesia?
Okay, so that's a very good question. Very good question. So theoretically, ERG will be a little bit slower under the sedation, but it is not a big problem. You can also record the ERG very good under the sedation, but the story is totally different for the VEP. VEP will be decreased a lot under the sedation if we compared it with stasis without the sedation. So my answer is you can use the ERG, whatever sedation or not sedation. The difference will not be very big, but it's a big concern when we use the VEP.
Okay. Let us continue to the question we had before about the differences between Caucasian and Asian eyes. So there is a good evidence that the ERG does differ between darkly pigmented and lightly pigmented retina, but your data suggests that more similarly pigmented individuals may vary less. Did your American cohort include subjects of African American heritage?
Okay, so in our study, the cohort of from the American is not so big. It about I remember it is about 60 patients. So among these 60 patients, some is Caucasians and some is African American and some is Asians. So among these 60 patients, there are no difference. That's what I say so far.
Okay, but maybe we can come back that later in the individual messages to go a little bit deeper into your reference data. I think this is a topic that we have many questions about it, and I think people are really awaiting that. Okay, next question. Can ERG be used in the neonatal intensive care unit to identify retinopathy of prematurity?
Sorry, again?
Can ERG be used in the neonatal intensive care unit to identify retinopathy of prematurity? So the ROP.
This is very, it's very specific questions. So I think the audience, there is a lot of specialists in our audience. Yeah. Actually, I have no so many experience for in RP patients because routinely ERG is not my priority when I diagnose or treat the ROP patients.
Okay.
Yeah. So because ERG can help me to tell what is the prognosis, but ERG cannot tell me if the treatment is needed.
Okay. So there are some specific questions regarding your cases.
Okay.
In case 2, CSNB, if the patient have trouble seeing at night?
Very good question. At the very beginning, I guess, I think all of the patients with the CSNB should have the complaint of night blindness. That's what the name tells us, right? But the fact is, at least 50% of the patients with CSNB, they don't think they have night blindness. They don't think, and their parents didn't find, any evidence of the night blindness in their children. I'm just thinking about why. And so far, my answer is, if the children is born with, CSMB was there when the children was born. If the children is used to see the world with their eyes with CSMB, they think the night is just like that. That's normal. So they have no complaint for the night blindness. Night blindness is always a big problem and a major complaint in the patients with RP, but similarly, not LCA. Because to me, RP and LCA, they are different. RP is always became predominant in the second decades or later, but LCA is there, the patient with a big problem with both the rod and cone, it is there when they are born. So patients, the children with LCA, some of them have no complaint of night blindness. That is very similar in CSMB. I would like to say it is just from my clinical experience, but actually I don't know if it is right or not.
Okay, thank you. I think that was really extensive answer. I have another one for case 3.
Okay.
Was the delay in the dark adapted a significant indicator of disease?
Yes, my answer is yes.
Okay. Rough estimate, in how many children can you do ERG non-sedated? When do you recommend sedation?
Okay, very good question. In my clinical practice, I think the age of the patients, they ranged from the newborn to the children about 14 years old, because that is the definition of our of the pediatric patients in my country. So if the patient is 4 years old or bigger, no sedation at all. We only use sedation in the patients under 4 years old.
Okay. Dr. Dink, we are approaching the end of this webinar. So I have a last question to you, which we ask each of our presenters. What next? What are your plans in your research work and with the extensive data you have in the ERG field?
Okay, I have a dream, and also I think I should make this dream to be a plan. So I'm thinking about how to make ERG popular. How to make it popular? So what we should do is we make the results understandable, and make this examination very easy and not time consuming. So I'm thinking about we should make a series of courses and to let every ophthalmologist to know to use the ERG, because ERG is very, very helpful to our clinical practice. So I think that is my research.
I really love that answer, I have to say. At LKC, we are all passionate about ERG, and that. We really think this test should be for many other people, so more used by ophthalmologists. And thank you very much for this exciting presentation and discussion. I really enjoyed that, and pediatric is very close to my heart. I just would like to say a few practical words to the audience. First of all of you will receive the recording of this session, as well as the list of publications of Dr. Dink. So just follow the link and you will have the recording and publication list. And not to forget, we are not ready with our series. I would like to invite you the May 31st, 6 p.m. London time. Unfortunately, Dr. Dink, that's the middle of the night for you. And Dr. Ruth Hamilton, a consultant from the NHS Greater Glasgow, also the children, will present her research on effect of maternal opioid use during pregnancy on children's vision. Again, very interesting topic, so please join us. And if you have any other questions, we are as passionate, Dr. Dink, as you are about the ERG, so even if you are not our customers, we still hope that ERG will become more and more popular. So once again, I wish all of you good evening and relaxing evening or the very good working day. And thank you for your attention, and please stay healthy, and hopefully see you the May 31st. Thank you. Once again, thank you, Dr. Dink.
Thank you. Thank you, everyone.
Thank you.